neurology examinations can be difficult sometimes because the signs may be not correct or the signs may be difficult to elicit, making the interpretation of the signs a bit difficult. There is upper motor neuron and lower motor neuron in our limbs examinations, mainly in the upper and lower limbs examinations. And in neurology, beside this, we have other things like cranial nerve, we have gaits, we have speech. But today I'll cover mostly the limb examinations, and then we'll go through some of the basics, and then we'll see whether you can come to a conclusion or diagnosis. In the limbs examinations, we divide the findings into upper and lower motor neuron based on anatomy. And remember, upper motor neurons start from cortex. So there are 6 levels of upper motor neuron. One is cortex. The second is corona radiata, internal capsule, brainstem, spinal cord, and anterior horn cell. So there are total 6 levels in the upper motor neuron. And then there are also 6 levels in the lower motor neuron. So we start from anterior horn cell. So lesion in anterior horn cell can have mixture of upper and lower motor neuron features. Then what happened in the next level is the roots, then the plexus, the nerve, the neuromuscular junction, and the muscles. And the nerve, we usually divide them broadly into polyneuropathy, which many nerves are involved, or mononeuropathy, which means only 1 or 2 nerves or a few nerves are involved. So in these conditions, you will see that we are able to divide the lesion into unilateral and bilateral. So think about it, which are unilateral, which are bilateral. So what we can see is that cortex lesion, corona radiata, internal capsules, brainstem, these are usually unilateral. So brainstem, occasionally it can be bilateral if the lesions are big or if it's in the basilar artery, but mostly unilateral, like Pica syndrome or lateral pons syndrome. Then they are unilateral. Whereas spinal cord and anterior horn cells, especially spinal cord, most often in the exam, we get bilateral spinal cord lesion. But occasionally you got brown sequoias, but not common now. Most often they are bilateral. Whereas for roots and plexus, they are unilateral. Whereas for nerve, if it's polyneuropathy, neuromuscular junction, and muscle, then they are bilateral. Okay, so from here you can understand that what happened to the arrangement or organization of pyramidal system is that certain part are control of one side, certain part are control of both limbs at the same time. So from here, we form our basis of understanding what are the likely lesions or what are the likely anatomical diagnosis in the lesions that we are looking for. And beside this, another things we usually look for is it more proximal or distal? So for anterior horn cell, the lesions are usually more distal. These are more distal. What other lesions which are more distal are usually nerve, like polyneuropathy, they are more distal as well. But sometimes it can be more proximal. For example, in CIDP Guillain-Barré, it can be more proximal. Whereas for muscle and neuromuscular junctions, they are usually proximal. So technically, this is a philosophical question now. Do you know why why myasthenia muscle disease, they are more proximal? Can anyone answer this philosophical question?
Bigger muscle bulk.
Yeah, huh? So in the neuromuscular junction lesion like myasthenia or muscle disease, the bigger the muscles, the more prominent is the symptom. So it doesn't mean that the distal muscles are normal. In fact, they are also abnormal, but because they are smaller muscles, the patients doesn't feel the weakness that much, and therefore they doesn't complain. And when we examine them, it's not that obvious. Whereas why the motor neuron disease and polyneuropathy, they are more distal is because they are length dependent, or they involve or affect the smaller muscles more. That's why the distals are weaker. Okay, so for example, in the motor neuron disease, the wasting, although they are both proximal and distal, but is more prominent in the distal region. Examination of the upper limb in, let's say, a 40 years old lady. Examine this lady, 40 years old, we realize that they are proximal wasting. Okay. What are the things that come through your mind? Limb girdle, okay. So limb girdle, muscular dystrophy, huh? So the first thing came to your mind is limb girdle. What else? Yeah, myopathy, huh? So when someone with bilateral wasting in the proximal muscles, then we classify them into the bilateral proximal category, okay? So remember, just now we divide the lesion, upper motor and lower motor neuron lesion into unilateral and bilateral. And we also divide them into proximal and distal. So in this case, we know that we are talking about this category, bilateral proximal weakness with wasting. So what are the likely pathology in this? First thing is we need to understand or determine, is it upper motor neuron or lower motor neuron? So now you try and think back. Try and think back. Is there any upper motor neuron lesion which are bilateral and proximal? Now go back to the chart just now. Is there anything of these which are proximal and bilateral? Which are the one? Could it be upper motor neuron or lower motor neuron? Is there any upper motor neuron lesion which are bilateral and proximal? Could it be cortex, coronal radiata, internal capsule, and brainstem? Answer is very unlikely. They are all unilateral mostly. How about spinal cord and anterior horn cell? Can a spinal cord lesion cause a bilateral proximal wasting or weakness?
Syringomyelia. Could it cause?
It can be, right? Syringomyelia, or in a better, broader terms, we call it central cord syndrome. Central cord besides syringomyelia can be a tumor or mass or other lesions in the center of the cord, or demyelination. Sometimes it can be in the central. Okay, so it can be central cord syndrome. Why is central cord being a possibility? Is because it involves the proximal muscles. So partly because it is mainly in the C5, C6 level. So if someone have a lesion in the C5, C6, which affect both left and right side, it will have weakness in the proximal. Possibility are things like cervical myelopathy. Any cervical lesion at C5 and 6 will involve both proximal upper limb. How about anterior horn cell? As I said, anterior horn cell are mostly distal, so it make it less likely. How about lower motor neuron? Which one is bilateral and proximal?
Neuromuscular and also the muscle.
Yes, correct. These two, Okay. How about nerve polyneuropathy?
It's usually distal, Prof.
Usually distal,
distal,
but can be proximal. As I said, certain motor predominant neuropathy, like Guillain-Barré and CIDP, they are more proximal later on. So initially they are distal, but they are ascending And because of the ascending weakness, later on, they become more proximal. So remember, for a bilateral proximal weakness, there are 4 possibilities. The first one is the spinal cord, mainly the cervical. And when we think about it, there are 2, either cervical myelopathy or central cord syndrome. Central cord, the commonest syndrome is syringomyelia. Okay. Whereas lower motor neuron, we have come to 3 possibilities. First one is either this is a neuromuscular junction, or whether this is a muscle disease, or whether this is a neuropathy, usually polyneuropathy, usually motor predominant polyneuropathy. Okay, because of this, there are 4 different possibility in these patients. So one is this spinal cord, neuromuscular junction, muscle, and neuropathy, nerve or polyneuropathy.
How about plexopathy, Prof?
Who are the people with bilateral plexus problem? It must be quite,
maybe unlikely lah.
Yeah, quite difficult to have this. Jane said limb girdle, and remember limb girdle is under muscles, but it's not exactly the diagnosis. So what happens is if someone say, what is the likely diagnosis? You say limb girdle, and you must understand under muscle disease, there are many other muscle disorders as well. And when you say limb girdle, you are only right in 1 out of maybe 10 or 20 possible differential. Okay, so technically you only have a 5% chance of getting it right. When you say this is muscle disease, then you have 1 out of 4 to say it is right. Technically, if you are considering lower motor neuron, then you are 3 out of 4 right. So even when someone with bilateral weakness, we don't jump into saying that this is limb girdle. We say that this could be either upper or lower motor neuron, and upper motor neuron lesion can be spinal cord. Low motor neuron lesion can be neuromuscular junction, muscle, or nerve. I will take away the neuromuscular junction in this case because neuromuscular junction, no wasting. After inspections, we check the tone. Okay, the tone is slightly reduced in the elbow joint. Elbow is reduced, but your wrist joint is normal. So it is very proximal. When you check the shoulder tone is also reduced. Okay, so you know it's proximal. The next thing is you check the power. The proximal power is 3/5. Distal power of the wrist and hands are 5/5. Tell you the reflexes. Do you have the diagnosis now before I proceed? The reflex determine the answer. Okay, yes. I give you the first scenario. So until now, your tone and power only tell you this is proximal, but you're still not too sure whether this is which one it is. Can spinal cord be still one of the possible differential? From here, we know that this is proximal, and it sounds more like lower motor neuron. So we know that the muscle and nerve are possible. So could it be still spinal cord? Yes, the tone, reduced tone doesn't mean it cannot be spinal cord, because remember, spinal cord, they can either have a lower motor neuron at the level of the cord lesion. So now I give you 3 scenarios, the reflexes. The first one is there is areflexia. The second one, the reflexes is possibly normal. The third one, the reflexes is brisk, especially in the supinator jerk or brachioradialis jerk, the supinator jerk. So these 3 scenarios have 3 differential. Can you tell me for scenario 1, what is the differential?
Polyneuropathy.
Yeah, correct. This is neuropathy, polyneuropathy. Second one?
Muscle disease.
Yeah, yeah, right. And the third one?
Spinal cord lesion.
Yeah, correct. Huh? Correct. So until reflexes, you are possibly already know what is the likely diagnosis, and whatever you do next is just to confirm. Huh? So when you check sensory, by now you should know in your mind, if this is areflexia, what is the likely diagnosis and so on. So sensory, we can have a reduced sensation, reduced sensations in the glove distribution, okay, or reduced sensation in the girdles, in the limb, in the shoulder, reduced sensation in the shoulder, or sensation is normal. So can you tell me what is the diagnosis for these three scenarios?
Polyneuropathy.
Yeah, polyneuropathy. If it's in the girdle, in the shoulder.
Could be a spinal cord.
Yeah, if it's normal, then it's muscles. So what I'm that demonstrate to you is that diagnosis is not made at the end of a short case examination. Diagnosis is made as early as inspections. Okay, so when we have still about 6 minutes, I'll quickly sum up this case. So when you see a patient with proximal, so when someone with a proximal wasting bilateral, then we know these are a proximal weakness. And in our analysis, we know that it can be upper motor neuron or lower motor neuron. And upper motor neuron, the diagnosis, anatomical diagnosis will be like spinal cord. Lower motor neuron can be neuromuscular junction, muscle, or nerve. And because there is wasting, we have take away neuromuscular junction as the possible differential. Nerve, polyneuropathy, if it's chronic like CIDP, they have wasting as well. And then we go on to tone, power, and reflexes. And by then, by reflexes, we will be able to tell whether this is likely polyneuropathy or myopathy or spinal cord lesion. We use the sensation to confirm. Technically, these are your differential diagnosis. When you have polyneuropathy, when you think that the lesion is likely polyneuropathy and they are with wasting. So what will be your pathology is very straightforward. Do you know that these are likely chronic? Chronic. And because of this, there are only a few differential. It is a chronic inflammatory demyelinating polyneuropathy like CIDP, or other neuropathy which are predominantly motor. Things like porphyria, things like hereditary, then they are predominantly motor. It can also cause this proximal wasting and weakness. If this is muscle, we call it myopathy. Then remember, myopathy, there are many different myopathy. Common myopathy are inflammatory myopathy. Second commonest myopathy are usually gene-related or dystrophic, dystrophic myopathy. And other myopathy, other types are things like endocrine myopathy. So inflammatory are either polymyositis and dermatomyositis. That's why we look for skin lesion. Dystrophic, what are the example of dystrophic myopathy?
Duchenne and Becker muscular
Yeah,
dystrophy.
Duchenne, Becker, correct. And then
limb
just now
girdle as well, I think.
mentioned limb girdle, and
Facioscapular humeral.
yeah, remember to look at the face. Facial FSHD. Endocrine are usually thyroid disease, thyrotoxic, or Cushing. For example, they can have proximal weakness, but usually no wasting. All right. Whereas spinal cord, then we know that these are either central cord syndrome, and one of the common example is syringomyelia. Or if it's not central, if it's just the whole cervical cord, which are cervical cord, like in transverse myelitis, multiple sclerosis, NMO. So remember, After we have determined what is the likely anatomy, either nerve, muscle, or spinal cord, then only we offer the differential in terms of the pathology. Then your diagnosis. This is what I will do. After I examine a case, I get all the signs, I'll make a simple presentations. For example, we know that this is lower motor neuron. This is likely muscle disease and likely polymyositis because of the muscle biopsy and there is no dermato sign. Then I'll make a presentations for this. So I say that this middle-aged lady have bilateral proximal wasting and weakness with a power of 305 and no power in the distal muscles. There was reduced tones mainly in the shoulder and elbow, and there are normal reflexes and sensory finding were normal. There is a muscle biopsy scar on the left biceps, and there is no other associated features. So in summary, I think this patient have a low motor neuron lesions secondary to a myopathy, and the likely pathological diagnosis is polymyositis. So I'll give you the second scenario, and one of you try to present. You know, this is low motor neuron. Think that this is neuropathy, and this is possibly a CIDP. Sometimes we need to try a few times, partly because the smoother you present, the more confidence you appear to be. Just follow the flow again. This is a simple flow. So this middle-aged lady was noted to have bilateral proximal wasting, and there were proximal weakness with a power of 305. Distal power was normal, and there were reduced tone and areflexia with a distal glove distribution sensory loss. And therefore, my diagnosis is that this patient has low motor neuron lesions, mainly polyneuropathy, and with the wastings, I will consider CIDP as my differential or other chronic neuropathy as my differential diagnosis. So let's say this patient has syringomyelia, which is a spinal cord lesion in the central cord region. This lady, middle-aged lady, has wasting of both proximal muscle and the power of shoulder abduction and the elbow flexions, which are C5, 6, you remember, are weak, whereas the elbow extension, the wrist power are all normal. So the tone was increased. There's absent bicep jerk, but there is brisk supinator jerk and tricep jerks. And there is a reduced sensations over C5 and 6 dermatomal distribution. So my diagnosis is cervical myelopathy, and which the differential include central cord syndrome like syringomyelia or cervical myelopathy like transverse myelitis or multiple sclerosis. Sometimes we need to be a bit more specific. If the patients have areflexia, you thought it's peripheral neuropathy. But what happened is when you examine the sensation, it is normal. Okay, so now we are going to a more challenging findings now. So now this lady has bilateral proximal wasting and weakness, areflexia, and normal sensation. So can one of you try to present this?
So I've examined this 40-year-old lady. She has bilateral proximal wasting on examination with reduced tone predominantly over the proximal muscle and reduced power proximal muscle scoring 3 out of 5 and distal muscle 5 out of 5. On examination of reflexes, noted that she is areflexic across all 3 muscles and with a normal sensation on examination. I would like to localize my anatomic lesion at the peripheral nerve in view of areflexia, and to explain on the normal sensation would likely to be a predominantly motor peripheral neuropathy.
Okay. Any differential?
My other differential would be probably is Arman.
Could it be a myopathy?
Could still be, but my reflexes are areflexic.
Yes.
So they'll be more supportive of peripheral nerve.
Okay, correct. Yes. Okay, good. So technically, in a conflicting finding like this, sometimes it can be because the findings are not correct. So when we talk about areflexia here, it could be truly areflexic, which is pointing towards peripheral neuropathy, or the reflexes are reduced, but we just didn't manage to elicit it. So it may be just reduced reflex, but not a true areflexia. Or in another scenario, actually the sensations are abnormal, but the patient abnormal sensations are mainly subjective. So if you ask them, do you have numbness? They will say, oh yes, I have numbness of the hand. But when you use pins, patients say, okay, normal. Then you thought, oh, sensory finding is normal, but it can be abnormal, but we just didn't manage to elicit it. So to be safe, if you come across a scenario like this, you try to be broad. So you can say that this patient has proximal wasting and weakness with a power of 3 or 5, reduced tone and areflexia bilaterally. The sensory finding were normal. All right. So my first differential, as what Dang Hong mentioned, can be peripheral neuropathy, predominantly motor, and the sensory loss can be subjective, and that's why I would like to ask the patient whether she has any numbness. My differential will be a myopathy because of normal sensory finding. Do you all get this? So when you are selling two differential, you say my provisional diagnosis is peripheral neuropathy, but my differential is myopathy based on the explanation just now. Then what happened is you are, trying to be broad and keep yourself safe. Just in case this is actually a myopathy or polymyositis and you miss the biopsy scar, then at least you are still salvageable.